My name is C.McWherter, and I'll be presenting this presentation on the effects of alternative birthing positions on pushing time experienced by laboring patients. To begin, I will provide some background on this subject matter. Birth is divided into 3 stages, the first of which is when the cervix is dilating or opening and the baby is moving down within the birth canal. The second of which is when the patient is actively pushing and concludes when the baby has been delivered. The third stage is when the placenta has been delivered. During the second stage, movement and changing positions is encouraged as it helps to move the pelvic bones, bringing the baby further down in the birth canal and relieving some pain, but many patients feel limited with their options. The experience of those in labor is highly variable, as are the protocols by certain facilities and providers. I will also add my patient interaction and experience with those delivering babies is centered around the opportunity I had a few years ago. I had the opportunity to volunteer of which happens to be Anne Arundel Medical Center, as well as the mother-baby unit and NICU units of the same hospital. I had been interested in labor and delivery nursing for quite some time, so I remember feeling excited about getting the chance to be in that environment, but I was also nervous that I would get there and not like it. Turns out I absolutely loved it, and on my first day, when I saw my first C-section of twins, I told myself there is nowhere else I could see myself working. Throughout the remainder of the program, I'll tell myself to stay open-minded, but it will be hard to convince me to go somewhere else. In terms of what I saw on the unit, I saw a vast majority of women were birthing in the traditional birthing positions as opposed to alternative positions. As far as there being a clinical problem, it is unfortunate that so many women feel limited with their options. Upwards of 68% of patients deliver their baby while on their backs in the traditional supine position, while 23% deliver in a semi-seated position, and 7% of patients deliver in non-supine positions, such as side-lying, hands and knees, and squatting. Currently, non-supine positions are not as common as supine pushing positions. For patients pregnant for the first time, pushing can take upwards of 50 minutes, while patients who have had previous pregnancies often take less time. Again, this is a circumstance that is highly variable among the specific patients and what their experiences are like within their different birthing atmospheres. For this project, the research centered around the following PICOT question. Is pushing in non-supine positions more effective than pushing in the supine position in reducing total pushing time for laboring patients? In this circumstance, the population would be patients in active labor. The intervention would be birthing in alternative or non-supine positions. The comparison done would be compared to pushing in supine or traditional lithotomy positions. The outcome would be shorter total pushing time and better experience for the patient, and the time frame would be during the second stage of labor, which again is when the patient is actively pushing out their baby. As someone with a passion for this subject matter, this is actually an issue I had began to research in my free time, so when assigned this project, I knew just where my research needed to focus. From personal experience and the few studies I found covering the subject matter, there were vast variations with practice within the clinical setting, which created unsatisfactory patient, staff, and organizational outcomes. To address the unsatisfactory outcomes and assess the variation, my research focused on seeing what is currently being done and what the results of the current practices were. To examine the effects of the birthing positions on the women's laboring time, pushing time, and overall outcomes, 5 studies were analyzed as part of this research. Overall, non-supine pushing positions were related to increased birth experiences and decreased pushing time, but each study had its own specific findings. One study found that 45.1% of the women giving birth needed an episiotomy, and the faster time it took for the baby to descend in the birth canal was associated with a free birthing position, otherwise known as a non-supine position. Another study found that the optimal fetal position was the left occipito-anterior position, and flexible sacrum positions were more beneficial for pubic bone movement. Both of those positions are again non-supine positions. A third study found that birth satisfaction, comfort, and postpartum oxytocin levels were highest in those who delivered in a vertical birthing chair. Another study found that most women end up delivering in the supine position because that is what they are told to do, and they do not think to question the medical professionals. That specific study was more of a qualitative study to find out the perspectives from the women in labor and the nurses or midwives caring for them, and was a fascinating take on this clinical phenomenon. Another study, and the last one looked at for this project, found that the results of delivering in a hands and knees position came with no further risks than a traditional supine position. Therefore, the alternative position should not be feared. For the case of the last study, it was found that in certain countries, the non-supine positions were thought to possibly be more dangerous, or professionals were scared to implement them, but that is found that those feelings are not necessary and they are just as safe, if not better, for the patient and overall outcomes. Now, in terms of the practical or clinical significance and the answer to this PICOT question, the positions entering labor are a nursing and patient-driven choice. Therefore, there is a need for implementing non-supine positions for better birth outcomes. It has been found that women who incorporate more movement and non-supine positions into their labor generally spend less time in the second stage of labor and less time pushing. It is important to consider, though, that even if a woman does everything she can to bring the baby down in the birth canal and to minimize pushing time, there is still no guarantee that the measures will be effective. For these reasons, there is not a definitive answer to the question if non-supine positions during the second stage of labor result in shorter pushing times. In terms of overall satisfaction and outcomes, those are generally more positive, but for specific pushing times, there is still much research to be conducted. Lastly, as a follow-up to the clinical significance, there are ways to improve the outcomes and continue the positive trajectory that has been found when patients and providers work together to birth in non-supine positions. Because of the improvements women have seen and experienced, it is recommended that non-supine pushing positions still be implemented despite not every patient experiencing the same benefits. Non-supine positions have been found to do more good than harm for laboring mothers, therefore need to be more encouraged in the medical setting. With experienced health professionals at the bedside, there is a need for women to feel more empowered to make this choice to deliver in a way they feel most comfortable and will do the most for them. To conclude this presentation, I have also included the references used. Thank you.